We'll move on to the next session. My wound leaks post arthroplasty. Yeah, thank you.
Thank you. That was an enthralling session. We'll move on to the arthroplasty session. For the next session, I'd like to invite Dr. Shubhranshu Mohanty and Dr. Anoop Dhamangaonkar as conveners. Can I request everybody in the audience to download Slido? It's an app that's available on Play Store and on Android Store. Slido will enable us to run real-time audience polls, SLIDO, and once you download it, WIROC MAX, WIROCMAX is the login password keyword. I'll request Anoop to take over.
Yeah, so without much ado, let me welcome our chairpersons for the session, Dr. Rajesh, Dharia, and Dr. Rakesh, Nair. Can we have them on stage? And for the panel, let me invite our panelists, Dr. Unmesh, Mahajan, Dr. Sanjay, Londhe, Dr. Rajkumar, Natesan, and Dr. Nikhil, Pradhan. So they will be joining us shortly. So please download the Slido app. We'll be having some interesting polls on Slido, and we'll run them through the presentation.
So, good morning, dear friends. Who is changing the slides? Please don't change the slides. Please don't change the slides. I will control. Okay. Good morning, dear friends. So we are running 5 minutes late now. So we'll be trying to compensate it, but hopefully that we have prepared it for 45 minutes. So we'll be completing little late. So as you know, the most dreaded complication after a arthroplasty is the leaking wound, and that's what we are going to discuss it today. Because if you see the literature, there is no uniformity of accepted definition of wound leakage. That how you define that it's a leaking wound. And second point is that there is lack of evidence based on the clinical guidelines for diagnosis and treatment of a leaking wound. So there are two important things which is lacking in the literature. That's why we are here with our experts so that we can throw you some guidelines on this. But from the literature, it is the wound is considered to be persistently leaking when it continues for more than 3 days after the index arthroplasty, and it requires a surgical intervention probably if the leakage persists beyond 5 to 7 days. However, there is an international consensus meeting on infection which showed Javed Parviz et al. They have mentioned that persistent wound leakage as a wound is leaking more than 2 into 2 centimeter. That means the dressing is soaked more than 2 into 2 centimeter for at least more than 3 days. Then you tell that the wound is leaking. And one need to do a wound care, bed rest, pressure bandage, and or antibiotics. But they recommended that one should not inadvertently just switch over and give a higher antibiotics. They are against the use of antibiotics in a persistent wound leakage. So this is the background knowledge in the literature. Based on that, we have our experts today. I am Shubhranshu Mohanty from Mumbai, and along with me, Dr. Anoop Dhamangaonkar is the convener for this session. We have Dr. Nikhil Pradhan, Mr. Nikhil Pradhan from UK, consultant orthopedic surgeon. Nikhil is a good friend. And Dr. Rajkumar from Coimbatore, all the way from Ganga Hospital. Dr. Unmesh Mahajan from Nagpur, and Dr. Sanjay Londhe from Mumbai. So we have an expert of panelist here, and we have two expert chairpersons with us, Dr. Rakesh, Nair, and Dr. Rajesh Dharia from Mumbai, to guide us and to monitor in our presentations. So now, through the Slido, I don't know how far you are acquainted with the Slido. The first questions which I am going to ask all of you, that why leaking wound is important. Leaking wound after TKR is associated with increased risk of wound infection, decreased risk of wound infection, no risk associated with wound infection, and 100% risk of wound infection. What we are worried about the infected total joint replacement, correct? So leaking wound associated with this, one of these you have to select.
Okay, can we have this project?
We have 10
please?
seconds to answer this. If you are not acquainted with Slido, then can we raise your hands?
Okay, project that on screen, please.
Those who are in favor of in option 1?
No, the QR code. Just scan the QR code and you can just put in a poll, or we can have a show of hands.
Okay. So it's pretty easier question just to warm you up that there is increased risk of wound infection. That is why we are worried about leaking wounds. Next little difficult question. As you know from the literature, leaking wound delays in the discharge of the patient. There is prolonged hospital bed occupancy. It is frustrating for the patient as well as the family. There is increased economic burden on healthcare and society, and persistent wound oozing after joint arthroplasty has been shown to be associated with increased risk of infection. So how to prevent, for the joint to go into the infection? Let's go to the second question. Which of the following is associated with less perioperative oozing after TKR? Less. Epidural anesthesia, spinal anesthesia, preemptive analgesia, and periarticular anesthesia. Can we have the poll? Okay. So 100% people tell that, okay. Okay. But if you go through the literature, the periarticular local anesthesia has got a less oozing of the wound. So subhastus approach, periarticular local anesthesia, and shorter tourniquet time. These are the three factors which are important for a less of wound oozing. Then we will go through the other factors. Let's go ahead with them presenting the cases. So we will discuss 4 cases here. And the first case, I would invite Dr. Anoop to present the first case.
Thank you, sir. So the first case is a case of a 69-year-old gentleman. He had presented to me with a valgus lax knee. He was on DMARDs and he had got pain and instability more on the left. So this was his gait video. So mind it that his ligaments are lax with significant medial laxity. He's got recurvatum as well. So his tissues are pretty lax. So we went ahead and did a semi-constraint design, the LCCK for him. And this is his wound, day 4 post-op. What would be your take on the same? So let me start with Dr. Sanjay Londhe. Day 4, the patient is home, discharged. As per definition, more than 2 by 2 centimeters. What do you do?
The size of the wound is more than 2 by 2 centimeters.
Yes.
And he's rheumatoid.
Yes. On DMARDs.
And he's getting thromboprophylaxis also.
Yes.
Clexane or rivaroxaban or something.
So he was on apixaban and he was on DMARDs that was continued, some of which that we'll discuss. As I mentioned, he was preoperatively on leflunomide, methotrexate and steroids.
And this is the first, on the day 4 you are noticed.
Yes,
it
this
first.
is day 4 post-op, the patient is home and he sends me this photograph with the soakage.
See, obviously he needs to come back to you. You need to personally yourself examine the wound. And I think apart from the wound size and its characteristics, the important thing to note is whether he has got a decreased range of motion of that particular joint. Suppose he was bending up to 90 or 100 degrees, and if it is bending less, then obviously the diagnosis is made for you, clinical sign and symptom. And if the wound is more than 2 by 2, I think by Parvez's criteria, you are almost obliged to take him to the theatre, paint and drape in a standard TKR fashion,
right,
and go layer by layer, wash it out and take it from there.
What about Dr. Mahajan? We'll take 2 at a time every
I
case.
think I won't go straight to theatre. First, if it's painful, the important part is extreme pain. Sudden increase in pain, loss of range, and leaking wound. One dressing is okay. 1 or 2 dressing is not a bad thing. I'll send even my fellow home, get a dressing sorted out, see how things after 48 hours, 24 hours rest, not too much of a exercise, and see after 48 hours how things are. And then I will see how things. But pain is the most important factor.
That's right.
A painful, very acute painful wound which is leaking needs to be sorted out.
Yes. So this is an early discharge. We'll just move ahead and take questions as on. As suggested, I sent my dresser home for dressing, a trained dresser with me. But these are a few points that we would want to consider. Would you consider or incriminate DMARDs to wound healing? This patient had significant diffusion, if you have noted, preoperatively as well. Would you stop steroids? Because these patients are known to flare up if they are not on steroid post-operatively.
My observation, there are two types of joints. One is a huge capacity inside. Once you open the thing, there's a large synovium. It's almost a half liter of fluid there. And one is very dry ones. Those with large joints, they always fill up eventually and can cause leakage. Right. And some people don't have at all those things. So those are the ones, but I think I won't stop DMARD more than 10 days. And steroids, I think they have to be given steroids because otherwise they're going to withdrawal. So what is sorted out with the rheumatologist has to be done.
Yes. About DMARDs, Dr. Pradhan, Mr. Pradhan, what would you say?
So I wouldn't stop any of your medication.
None of them? Not even?
None of them. I would say that if you are dealing with these patients, operate with them without a tourniquet so that you have hemostasis from the start. It's very difficult to get hemostasis once the implant is in. So I would say for these patients, start without a tourniquet, and then if you've caught all the bleeders to start with, you will have less chances of a huge hemarthrosis. What Unmesh has said is absolutely right. But I think with that first case where you're seeing an opening, we do have a low threshold for using what we call as a PICO dressing, which is a suction dressing, and that tends to keep the wound dry. Clinically, if you're not suspecting infection, you could give it a couple of days. But if you're suspecting infection, you're better off just going in.
Right. So about DMARDs,
before you move on, most important point is that, what panelists suggested, you will send the fellow, you send your dresser. Personally, I would like to check the wound myself. If you are a surgeon, you must call the patient, you check the wound, because the assessment of the inflammation around the wound, these are the critical assessment that whether to intervene, not to intervene, this is your decision. So personally, I think a surgeon should check the wound. Yes, please.
Just one more thing. Yeah. In this, first when we see this kind of, first time when we note, as he asked about the thromboprophylaxis, it is better to stop for a day or two and then see. And sometimes it slowly comes down. So we should not jump in and think that it's an infection.
And avoid flexion or active physio. Yeah. So
and put the patient on a knee brace, avoid movements, CPM, all those things. Give some rest. Many a times it will settle down.
Right, right. So we move on about DMARDs. Understand that there is an increased risk of infection, therefore be aggressive in RA. Post-op flare-ups are common. Methotrexate is given up now that we have to continue that. Leflunomide also we continue as an immunomodulator. Tocilizumab, it's worthwhile waiting for a month before surgery. Tofacitinib, widely marketed and used these days, to be stopped for 7 days preoperatively. This is the latest literature. We come across SLE cases as well. Non-severe ones, that's what we tackle with for joint replacements. Tacrolimus and mycophenolate. Mycophenolate you withhold, whereas tacrolimus you can continue. Okay, so these are about the DMARDs. What about intraoperative factors? We've discussed the tourniquet. Dr. Dharia, what about the drain? Would you keep the drain in these patients because they have flare-ups?
I was just going to ask you that. So, when did you remove the drain?
It was third day. So 48 hours and we removed it.
How much was the...
So first day, typically they throw up around 110 cc of drain. Next day, they go down to almost 30 to 40 cc. And third day, they have less than 15 cc. That's the typical pattern in RA that I've seen.
So that's what happened in this case as well?
Yes, nothing special. We had a dry drain and then we removed it.
Yeah, these are, obviously one would keep a drain in such patients. It is very mandatory to keep it and as monitored, as you've done it. So
yes,
that's a good.
Dr. Nair, what about anticoagulants? We've used NOAX here.
I don't use anticoagulants. So in this case, I would say we would stop it anyway for a day or two.
Right.
And I wouldn't be very aggressive on the day 4. On this, I would wait successive dressings and then take a watch and decide what to do next.
Right. So about tourniquet, we have decided that yes, in these cases we may keep it, but there is an overall increased risk of infection and increased blood loss, and transfusions and hospital stays do increase. Regarding anticoagulants, just a quick few points. Dagabatran is a direct thrombin inhibitor. It is the most dreaded or incriminating drug for post-operative ooze, hence used with extreme vigilance. Apixaban, though we are rampantly using right now, it has been licensed FDA-wise for VTE treatment, not for VTE prophylaxis, though we are still using it. The treatment or VT prophylaxis, Xarelto is what is recommended or FDA approved, and the remaining we can definitely use them. So this is about the NOAX. Be very careful of using direct thrombin inhibitors. So next case. So this is my case. Typically these RA patients have got a history of repeated injections in the past, and hence I make it a point to send multiple samples during the operative procedure as well. Is that a practice that we follow normally in your practice, Dr. Londhe, sir? Dr. Mahajan, yeah.
I don't, unless, see, once when I started my practice, initially I was scared of all those dirty effusions of rheumatoid, and came to know there is no point doing anything of those things, just go ahead, clean it, and hardly anything happens. So I'm not really doing it unless there's something else which is happening.
Right.
I think if the patient is clinically and serologically proven rheumatoid, then there is no need to send a sample. Okay. Saying that, if you are operating an osteoarthritic patient, and if I see a very red angry synovium, I send a sample. We have an international publication also. Almost less than 2 or 3% of the patients, you will be surprised, you will get a rheumatoid or hypertrophic synovium there.
Would you take a sample all from the sinus?
Osteoarthritis have this typical red thing, and yes, it is wise to send.
Would you take a sample from the discharge which is coming out through the wound?
A swab.
There's no point because it's contamination. It's a pure contamination with the skin flora. So
that's right. So no swabbing, it's only tissues.
Anoop, that first question, sample in each RA case, don't we think we are dealing with, means our majority of our female patients are seronegative RA? You think they're coming with primary osteo, means that question of sample in each RA case, all these young ladies who are coming in at 45 to 55, they won't have anything. So they're all seronegative, immunocompromised.
Absolutely agreed with you. It's not a global dictum that we need to send samples. So that's the take-home message. Okay.
So one important point is that do not try to take the samples from the discharge, because there will be growth of the skin flora or something like that. So you won't get a true picture of what is the infection inside. Always it's better to take samples from deep structures, which we'll discuss about a little later. Okay, if at all if you want to take a sample, then wipe out with a normal saline of that wound area, press the knee or press the wound, and see if there is a fluid which is coming out exuberantly. Then you can take the sample after cleaning with a normal saline.
Yeah, so we move on with the story, then take opinions. I rested the patient, gave him a brace, restricted his physiotherapy, stopped with his anticoagulants. But this, I started moving in my chair. So day 6 post-op, you see this wound, day 6 evening, and I call him to my office. Okay, so this is the question.
The next question is that what will you do now? Day 6, the patient had increased oozing. So you will do ESR and CRP, change antibiotics, stop knee flexion, watchful expectancy.
Can stop knee flexion for a day or two.
What is the opinion of the house?
10 seconds.
So he's day 6 post-op. You'd expect that to go up any which way.
No, the patient is already a rheumatoid.
And he's early post-op.
Okay. So opinion of the house is to ESR CRP. Okay, we'll go ahead.
We'll go ahead. Yes, so we go ahead. Can you switch on? Can you switch to the screen? Okay, so this patient is when I see him. He's actively discharging. He's at this stage given only 5 doses of typical antibiotics that I give. No prolonged dose of antibiotics. He's not on antibiotics now. He's day 6 post-op, and this is his ooze. Mr. Pradhan, what would be your take?
So slight different take. We involve our microbiologist on day 1. Don't use a tourniquet at all. We don't use a drain. We do take a sample the first time we see a discharge, which goes to the microbiology. I cannot make a decision on antibiotics.
First time during index surgery, you mean?
No, when there is a leaky wound.
Okay.
That sample gives us an idea of whether there is a secondary bacterial infection that might set in the future. We do an ESR because that gives a baseline ESR for future. It will be raised, but it gives us an idea of what to do, say on day 6. So now you've got a day 2 discharge, and then you've got a day 6 discharge. You see a difference in ESR. We don't put them on antibiotics. Antibiotics cannot be given until you open the wound.
Dr. Rajkumar, what would be your take also?
Yeah, see here this looks more of an hematoma collection which is coming out. If you see the swelling, the picture, it is not so much induration is not there.
Perfect.
It doesn't look like a frank infection. So there is a hematoma kind of thing coming out.
Yes.
So we need to that has to come out. Because this is not going to stop. So this is the situation where without doing much, you just give a small washout, clear off all the residual hematomas, clotted bloods inside, and then clean it up nicely. Perfect. This will settle. If we don't do that, this patient, rheumatoid, immunocompromised, on steroids, the chances of infection goes in. So this is not infected, but the swelling is little huge. So
perfect. So point well taken. If you have a serous serosanguinous discharge, which is early perioperatively, there's an entity called liquefying hematoma. And what I did for this patient, that's what I expected. If you look at his labs, his proteins are very low. His hemoglobin is low, and proteins are basically incremented. You'll see that very commonly in your CKD patients as well. So if they are low on proteins, they have an entity, they have got a hematoma which is liquefying, and it keeps on leaching every time. On top of it, we have put in staples, which is again contrary to the philosophy of leaking wounds, where we possibly might use sutures. Okay, so in those particular cases, what would be your choice of?
So before nutrition, contrary to our belief, ESR and CRP will not give you a diagnosis. So rather, pre-operatively ESR and CRP should have been done. In each and every patient of knee or hip arthroplasty, do a ESR CRP pre-operatively, which will be your baseline ESR and CRP. And it takes about 3 weeks. After surgery, the ESR CRP increases because of high inflammatory markers, and it settles down at 3 weeks' time. And later on, ESR CRP may be helpful, but not within 3 weeks' time. But before we move on to, Dr. Londhe has got some publications about CRP. Would you share with the delegates?
Actually, I was caught with this type of situation. I think all of us have caught up with this situation. Patient coming back at about 4 weeks or 6 weeks, little bit of hot, warm joint, patient complains of some pain, and we do a CRP, and the CRP is high. And then I look at the literature. There is one paper from Bob Dunsmore from Scotland, and there were a couple of papers from America. And they were advocating that the CRP has to come down at about 6 weeks, roughly, after the operation. And unfortunately, there was no Indian literature. So we did a study for unilateral TKR as well as simultaneous bilateral TKR. Simultaneous bilateral TKR, there is no study of CRP anywhere in the world. And in our sample, what we found in a unilateral TKR in Indian patients, the CRP takes almost 8 to 10 weeks to come down. And in a simultaneous bilateral TKR patient, Dr. Ravisha was also there in that study, it took almost 14 to 16 weeks for the CRP to come down. And these were not infective patients, So I think probably in Indian population, we have some sort of a pro-inflammatory state or something. And our CRPs are coming down little late as compared to England. As Mr. Pradhan had said, I think it is the trend of the CRP which is most important. You do an index CRP before the operation and after the operation. If the CRP is coming down, you're okay. But if it suddenly shoots up, then probably you're dealing with something.
So it is the trend of ESR CRP, which is more important. Let us move ahead. After the first case is over, we can invite.
Yeah. So choice of protein intake, typically IV albumin is not a go-getter in the immediate perioperatively. You just increase his oral intake because metabolized proteins are better for healing. So amongst other factors in nutrition, serum transferrin is giving a lot of value. In those undernourished patients, avoid bilateral procedures, and elderly patients definitely have wound healing problems, especially with patients with SLE. Delay your suture removal at around 3 to 3.5 weeks. So I had done a DARE for this, not a typical DARE, I would rather say a washout for this patient with extensive synovial debridement, polyexchange, no tourniquet was used, lavage, betadine, lavage again, meticulous hemostasis, no drain, and incision wound vac, high protein diet. We'll discuss the steps of DARE in Dr. Mohanty's case as we go by. Literature about of VAC. I mean, how many of you really use VAC, Dr. Mahajan?
Unless there's a skin deficit. I think if you do a good washout and everything, it should be fine. There's no need for a regular VAC. It increases the morbidity, the cost and everything. And patient gets scared, what is happening now again? It's going to be process. And once you start, you can't stop for a couple of more days. So true. I don't think it's required all the time.
So just a bit of literature before we move on. VAC is coming, especially wound VAC or incision VAC, Pico dressings are coming up big time, and they have the mechanism of action of micro deformation by which they draw the wounds closer, micro deformation of facilitating proliferative cell therapy. It removes the fluid and gets you a dry wound. It is not very useful in primary cases because it runs a high risk of blistering. So you need to be very careful and meticulous about where you're placing the sponge. You need to have cellophane dressings on the skin, so the increased risk of blistering is a possibility. But in revision total joint replacement, this is a game changer. That's what we have the literature. It significantly decreases SSI. Again, no growth. No growth again after a wash. What will be your choice of antibiotics and duration of antibiotics? If I may ask Mr. Pradhan, Dr. Natesan, if at all.
See, but even though there is no growth for this, but some prophylactic antibiotics is preferable. So a basic, like even if you can go ahead with the cefuroxime 3rd generation cephalosporin for 5 days since the wound you have opened and cleaned and washed out. So that will be my choice for 5 days till the wound settles. And once you are discharging, you can stop the antibiotics. That will be my choice.
Perfect.
So we always start on teicoplanin and gentamicin. That gives you a 72-hour cover. You take at least 5 samples when you do your day. And then based on what results you get from that, you can then decide whether you want to continue antibiotics or not.
Perfect.
So primarily if it's not infected, you want one quick point on immobilization. If we immobilize and the wound is distal, then we elevate and give a Zimmer splint type scenario. Right. If it's in the middle, then that's because your pumping action is there, so we stop range of motion.
Perfect. Perfect. Site of discharge. Okay. So this is 1 week post-vac, 2 weeks, sutures removed, patient is happy. So that's the end of the story. It's now been almost a year and a half. So far so good, fingers crossed. Waiting for his other knee. So we go on to the next case.
So before we go into the next case, any questions from the audience?
What was the antibiotic coverage? Sorry, Dr. Mohanty.
Just to allow 2 questions.
Antibiotic coverage you gave after 2 weeks?
What antibiotics coverage you have given?
Okay. So typically for this patient, for the first we had given the cephalosporin for 5 doses. The next we had given Magnex Fort, that is cefoperazone sulbactam, as well as oral Norflox because he had got co-incumbent UTI as well. So
after
that had
2
made
weeks,
suitable.
after 2 weeks was any antibiotic?
Short comment or question, please.
2 weeks is what we had given.
We are running short of time.
Just one question is that you said hemoglobin was 8.8 post-op. How much was it pre-op?
Pre-operatively it was around 11, without which I don't 10 plus.
Yeah.
Shubhranshu, you mentioned about pre-op CRP. Now, in our scenario, if we have a CRP in a pre-op workup, patient is clinically fine, there are no signs of infection, and CRP is 15. Now what to do? You cannot go ahead with that. You cannot find a focus of infection. So what is the value of that CRP?
That may be high, but that will give you the baseline CRP.
But with a CRP of 15, can you go ahead with the primary joint replacement?
Yeah, clinically if the patient is fine. In rheumatoid CRP is high. In inflammatory arthritis it is high. So
diabetics are known to have a high CRP.
High CRP and high.
So I think you look clinically. What I'm saying is whatever said and done, what Londhe said, even our patients have CRP post-op.
Correct.
But even the patient is absolutely clean,
So
there is
if
no
patient
issues.
is clinically fine, what's the use of that CRP?
No, you should trend.
Yeah, so we'll discuss it later on.
Trend you do later on, whenever there is a
Dr.
problem.
Pachale's comment, then we'll go on to the next case.
Huh.
Okay, we'll discuss it later on.
Regarding this CRP, if it is high, there has to be some cause. Please try to find out. Just don't ignore. You have to find out whether these patients are immunocompromised somewhere. Otherwise, that will not come. One important thing that you just showed 48 hours culture. Please put an extended culture for this patient. They will grow. More than 1/3 of these patients will grow something. 2 weeks. Yeah. Get an extended culture. That is very important.
Oral rifampicin for 3 weeks is good for
We'll move and we'll discuss about later on. So second case, a 64 years old female, well-controlled diabetic, underwent bilateral TCAR 3 weeks back. One suture site and suture removal of the left knee shows overlapping of the skin margins, throwing some serous discharge. Discharge continued in spite of daily dressing. That is the post-operative X-ray, and this is how it presented after 3 weeks.
I would open it.
Now what to do? Wait and watch, X-ray to see for any loosening of the components, ESR CRP exploration.
I think ESR CRP
Let's see
exploration.
audience poll. Just give 10 seconds.
Can we switch?
Yeah. Switch to Slido. No. Okay.
Okay, we have got the poll. Exploration is 80%.
80% exploration, 20%, 86% exploration, ESR, CRP 14%. Okay, most of them are going for exploration. Yes, Dr. Rajkumar.
This is totally different from the other wound clinically. So it is already opened out. The edges are all avascular. It is definitely, it needs open out, debridement, secondary suturing, clean it, take lot of samples. Otherwise, this is not going to heal and it is going to get infected in a big way. So this is definitely.
What is UK experience, Nikhil?
I would say the same. I mean, you can't ignore this wound. You have to explore with investigation.
Okay, so all of us agree that it needs exploration. So increase serious discharge with increased activity, exploration in the operating room, and ensure deep fossa closure, deep intraoperative cultures. So this is what is known as DIRE. So let us discuss about little bit of DIRE, which is extremely important. So Sanjay, what is your take on DIRE? What are the, just tell us key steps in the DIRE.
I think basically you need to be very aggressive. Whatever looks suspicious, you have to remove. Give a thorough wash, because the best solution to pollution is dilution. And depending on your philosophy, you may change a insert, plastic. But if I am suspecting strongly in the infective part, I think I will change the plastic also.
Okay. Dr. Mahajan?
I think 5 to 6 samples, no tunicate whatsoever. No tunicate is important. Open up, and I would rather change the insert all the time. 99.99, unless it's extremely difficult to dislocate, I would changing the insert in all my day procedures. And rifampicin post-op for 3 months to avoid biofilm.
Okay, so these are the 5 most important points, steps in DIRE. Remember, thorough debridement is the key of success of the DIRE. Next, exchange the, mobile parts. If it is a monoblock, tibia, of course, you cannot do. But whenever you do a lot of synovectomy and take out everything, joint becomes little lax. You have to exchange the polyethylene. That's why you have to keep all these trial polyethylene, thicker polyethylene trial components as well as the original components pertaining to that particular implant. And you have to, curate out at the metal cement interface or cement bone interface, because there the granulation tissue, erodes through the bone and causes osteolysis. Send culture, and as Dr. Pachere pointed out, you have to do extended culture. Tell your microbiologist, and you have to send tissue cultures, multiple tissue cultures, and take all unobserved sutures and copious lavage, about 6 to 9 liters of normal saline lavage. So these are the steps of the DIRE. So do a thorough synovectomy. Take out all the synovium from parapatellar gutter, suprapatellar pouch, everything. Then take out the polyethylene so that you reach the posterior aspect of the joint. And as I have shown in the video, that you curate out at that interface, that is more important, and send multiple tissue samples for culture as well as the histopathology. Why histopathology? It is important in our country to rule out tuberculosis. As well as sometimes fungal infection is there, you may see in the histopathology, fungal hyphae, so that you can do a fungal culture. Get the culture bottles into the theatre and retrieve the samples and put it directly into the culture medium, so that you don't waste the time in the transportation of the samples. And tell your microbiologist to do extended culture until about 2 weeks. Do a thorough lavage. Normally I use hydrogen peroxide betadine. Some people don't like hydrogen peroxide in the tissues because it's got more of tissue necrosis. And closure should be done with monofilament nylon, because that has got least chances of infection compared to staples or braided sutures. And do you use any adjuvants, Rajkumar, in your DIRE procedure?
In DIRE, it is not needed actually. See, because it is more of a you are not able to elicit the organism. So here you need to have a quick debridement and whatever steps you have meant. I don't use beads in the DIRE procedure.
Nikhil?
So we don't use anything. We have a low threshold for aspiration and sending it off to microbiology before we do our DIRE. And if we know the antibiotic, it helps us. So if there is time, then we normally do aspirate.
Yeah.
There are some reports which shows.
Rajesh, you have anything? Just one. No, anything to add? Do you use any of this?
I would not. I mean, at this stage, using the thing is, I wouldn't do it. Because you essentially you are trying to save the wound, it's clean,
and adding something more into it, which will going to take a long time to absorb, may give rise to more infection.
Okay.
Goes
So
from 3
we'll
to
just
6
move
weeks,
ahead.
I would use antibiotic cement. Put the beads in at least.
Okay, so it's your choice. So one has to do a sufficient irrigation, add antibiotics to the fluid. Use a pulse lavage in low pressure. Don't use in a high pressure, because high pressure would introduce the infection to the deeper structures. And anti-biofilm agent, one should use one of these, acetic acid, benzalkonium, chlorhexidine. Nowadays we are using chlorhexidine in the normal saline mixed with normal saline, because that is considered as an anti-biofilm agent which will take out the biofilm. And local antibiotics, I put calcium sulfate pellets along with antibiotics, but that varies from, as you can see from the panelists, some people don't use it, but I put in the deeper structures like suprapatellar pouch, parapatellar gutters, and the posterior aspect of the joint, so that to take care of the local infection. Some people put PMM beads, collagen fleece, all these structures. So this is the same patient, 64 years old female, bilateral sequential TCAR. This is a Nair procedure done with a polyethylene, thicker polyethylene, and the patient is infection free for about 4.5 years now. Now that is the function of the patient, almost 100 to 110 degree flexion. Now before you go on to the next case, any questions from the audience? Yes sir, Dr. Vaidya.
Although I came late, I just want to churn some discussion on NGS, next generation sequencing. It says that no wound is sterile. As Pachero was pointing out, first culture, second culture, something will come out of it. And if your microbiologist is good, she will direct you towards a particular antibiotic combination.
Okay, thank you. Next generation sequencing is coming, is not available in every city. Very few cities in India it is available, so it is just coming into the market. So let's move on to the next case. 69 years old male, diabetic, hypertensive, chronic renal failure, right total knee was done 2 years back, discharging sinus, anteromedial aspect of the leg, no systemic symptoms, pain, swelling, range of movements 10 to 100 degrees. So Sanjay, what is your take on this?
I think by definition, Parvezi, discharging sinus at this point is infection unless proved otherwise. So depending on your philosophy, 1 stage or 2 stage revision. I think in our context, 2 stage revision.
So all of us would agree there is no big deal about it, that when there is a discharging sinus present, so that will goes to, that goes with the definition of this AOS guideline. The first important point, sinus tract communicating the prosthesis. So it diagnoses the infection. Dr. Unmesh, would you do any investigations at this stage?
Of course, basic investigations, of course, CBC, CRP, everything has to be done, just to make sure we need to trend later on. There's no point aspirating anything from the joint is anyway open. And I think straight away go ahead, culture, 5, 6 cultures and everything, 2 stage. Apart from that, you might check all this low immunity status issues. And fungus.
Any of the panelists who do a single stage, 1 stage?
No, no single stage. Definitely it is 2 stage. But only to quickly add upon the clinical picture which you showed. So in this stage, when we are going, better 2 things. One is not to start any antibiotics in this case. And also if the patient is on any chronic antibiotic, stop it for 2 to 3 weeks. Because this is not an emergency situation. Stop for 2 to 3 weeks, then plan the surgery and take a lot of samples and then start on antibiotics.
And you said he is diabetic. So what is the sugar level and insulin, or what is it? Most important.
That of course, that's the medical part. We need to control the diabetes. That the other things we are not discussing here. Yeah, Nikhil.
Shubhranshu, if it's not an immune compromised patient, diabetes under control, we would aspirate this. If you get a bug, and if the soft tissue envelope is good, then we would consider a 1 stage, wherein we do the first stage, we actually take a break, we would then re-drape everything, new instruments, and then do the second stage. But yes, if it's not immune compromised, we know the bug, then we have a low threshold for going for a 1 stage.
So let's move ahead. We have sort of time. So there are the indications of doing single stage, but most of the surgeons in our country, we follow the 2 stage reconstruction. So we'll just move ahead. And this is the patient. This is, after removal of the component, this is the first stage reconstruction. This is how we prepare our cement spacers and we put it there. So this is antibiotic coated cement spacers, along with I put the calcium sulfate pellets there impregnated with antibiotics. That is the X-ray. And at the second stage reconstruction, this is almost 6 years follow-up of this patient after 2-stage reconstruction. Though 1-stage reconstruction has got a superior functional outcome and less of healthcare expense, but it has got a 33.4% increased chances of reinfection compared to 2-stage. So we have to weigh your patient's money and healthcare cost, everything to do a 1-stage or 2-stage. For 1-stage, at least you should have a trained personnel in your theatre and in your setup. So before we close, let's have a quickly case number 4.
Yeah, so we have the case 4 with clear take-home messages. Okay, this is a 20-year-old male who is now 22 months post-op with pain discharging sinuses since 8 months after fixation with knee contracture and ankylosed hip. So this is post-implant removal. Immediately post-op, you can see signs of infection with thickened cortex, irregularity. So indicating that there's osteomyelitis through the canal. And this is now growing MRSA after the cultures, after the implant removal. It is sensitive to linezolid, vancomycin, teicoplanin, and the patient was given 6 weeks of antibiotics. This is 18 months post-implant removal. He has got an ankylosed hip with a flexion deformity at the knee, walks with a limp, no signs of infection. Discharge has healed. CBC, ESR, CRP are normal. What would be your plan? He wishes a good function.
I think I would give him a fair chance of hip replacement, provided he understands this high risk of infection.
Right.
Around 25% chance that he has an infection, 1 in 4 or probably something like that.
Right.
There's a very possibility of getting infected. So if he takes a chance, well and good.
So we waited for almost 18 months. We did a THR. So day 14 post-op, he throws up with a cerebrillant discharge with fever since 2 days. His WBC count is 12,000, ESR is 65, CRP is 32. Again, the culture grows MRSA. Sensitive to the same kind of drugs. He underwent debridement, vancomycin, stimulant beads at that time. But after this culture grew, he was given IV teicoplanin for 8 weeks and oral rifampicin for 3 months.
So quick one on this. So we would have screened the patient for MRSA before the second stage, pre-op?
Yes, so he was all clean. He was aspirated,
He was clean
that was
then,
negative.
And you had a bug which you knew, so we would have put him on antibiotics for 3 months post-op.
Yes. After the first implant removal, yes, we knew the bug. We did
After the total hip, we would have put him on the same antibiotics.
As per the culture pattern, yeah.
No, for 3 months post-op, irrespective.
Okay, okay.
Now, looking at this one, I was about to tell, see, it's almost like fused hip
Yes,
there.
it is a fused hip.
Young chap, intramedullary osteomyelitis, 18 months is not too good time to go ahead and do a THR. I will wait. In fact, I will wait for some more time because osteomyelitis proven intramedullary, it is high chance of infection.
Good point.
So I would not do a THR.
Good take-home point.
That is why, remember this intramedullary infection, what Dr. Rajkumar is mentioning is extremely important. That's how it leads to recurrence of infection. So while doing total hip replacement, I would put intramedullary stimulant along with, vancomycin, etc. so that, less chances of infection at least. Whether go for a first stage or a second stage.
So
Please go ahead.
intramedullary drug delivery system in the medullary canal is important, and know the bug. MRSA is the worst bug that you can find because it is just persistent as far as infection goes. So this is 3 months post-op. Patient is walking comfortably, he has well-fixed implants, but still he has got an on and off discharge. This is 9 months post-op, still on and off discharge. Again, MRSA, sensitive to linezolid, vancomycin, teicoplanin with well-fixed implants. So what do you do with a patient who is throwing up discharge almost 9 months after the surgery with an MRSA proven with well-fixed implants? Okay, so...
One quick thing here, that we would have used a cemented implant in this case and use antibiotic-loaded cement.
Right. That's the endoclinic.
So right now, redebridement, retain the components, 2-stage revision, excision arthroplasty, watchful expectancy.
Okay, so a quick review. There is no proof of eradication of infection in most of these cases. Be sure of that. It's worthwhile to wait at least for 2 years before you complete the second stage or a definitive procedure. When we have MRSA, even a DARE procedure is likely to fail. Not including rifampicin is the biggest mistake with MRSA. So always use rifampicin. Always use 2 antibiotics at least. Rifampicin with quinolones has the highest success rate. We can use linezolid, but bear in mind the renal toxicity, and daptomycin is definitely promising.
So before we conclude, let's have 1 or 2 questions regarding the antibiotics. Though rifampicin and quinolones, these are the 2 antibiotics which are effective against the biofilm. But in our country, at least we keep rifampicin as a reserve antibiotics because of development of resistance. Because our country, patients are more prone to tuberculosis and all. We don't want to develop a rifampicin resistance among the community. So I prefer to use quinolones, which is better tolerated. Oral form is available. That's why quinolone is preferable than rifampicin in these cases. 1 or 2 questions. Yes, Satish, you wanted to ask something. 1 second, Satish.
18 months would be too short a period. How long would you wait then?
It's a very arbitrary question. There is no fixed time limit, but at least 18 looks little shorter. Like you wait for a couple of years, like 2 years, 3 years, because his hip is already fused.
So 18 months, if radiologically the intramedullary infection has not progressed, all the markers are quiet, I think that is long enough to wait for osteomyelitis.
No, 1 in 4 chance of infection. You have to understand that
but
part.
will that reduce by waiting 24 months?
Yeah, at least you are safer.
Now, the chances.
Okay, we have to close the session. Just a short comment. Yeah.
I want to ask one question. What should you do, or what is mandatory before you do the hip replacement? Would it not be prudent to sort of check intramedullary sampling?
Get MRI of the hip, MRI of the shaft.
Yeah, the whole
MRI
thing.
will give us an indication of bone marrow edema.
We'll discuss about it later.
Also, they used to say in the past, 5 years post-infection settling, you should wait.
I would agree with Rajkumar.
That's the difficulty, situation when there are resistant organisms.
You could do
which are
an MR or you could do a SPECT scan.
So let us, before we close, take home messages. First thing is that the time to dryness of the wound after a joint replacement depends on the wound length, body mass index, estimated volume of blood in dissected tissues, and length of hospital stay. It is not associated with duration of surgery or ASA grade of the patient. Second thing is systemic comorbidities affects the healing. For diabetics, the perioperative euglycemia is extremely important. At least on the first postoperative day, if your sugar or HGT level is less than 140, then very unlikely the patient is going to develop a wound discharge. Rheumatoid disease, renal liver disease, corticosteroid medication, poor nutrition. Your pre-op serum albumin level should be more than 3.5 and serum transferrin should be more than 200. That should be the level. Otherwise, you improve it. HIV patients, CD4 count should be more than 200, and one should ideally quit smoking before joint replacement surgery. The third is that if there is a superficial serous discharge, there is thin serosanguinous discharge, one need to take local wound care, immobilize this patient, avoid knee flexion. If there is superficial infection, thin serosanguinous with cellulitis, do a operative debridement, give antibiotics. Sometimes suture material also, stitch abscess, these are told on stitch abscess. If there is deep serous discharge, thicker serosanguinous discharge, do a operative debridement, do a proper fascial closure, what is known as Nair procedure. But if there is a deep infection, thicker purulent discharge, you have to do a operative debridement, antibiotics, and do a 2-stage reconstruction. I thank you, all of you, for attending this session. We thank all our panelists and chairpersons, and we close the session and hand over to the organizers. Thank you very much.
While they take the photograph, please hang on for a very interesting session. I would now like to call our chairperson, Dr. Mahajan, to chair the next session. So audience, we really want to know whether a good bipolar hemiarthroplasty will give us as good functions as a hip surgeon. That will know, sir.